So we've had lots of background from Professor Bedford Russell and others, so I won't go into too much detail around Group B strep disease, but we know it causes a range of different diseases in humans, including meningitis, bacteremia, pneumonia, and soft tissue infections and osteomyelitis. And rightly so, the focus of public health activity and clinical and research activity to date has really been on neonatal disease, given the very high incidence of disease in the UK and elsewhere, and of course because there are opportunities for prevention of this disease. However, there is and continues to be quite a lot of concern in many countries in North America and Europe over a rise in adult disease. And with this in mind, I decided in my talk to give an overview of the epidemiology of invasive GBS disease across all age groups, not just focusing on infants, to look at changes since 1991, and then to do a little bit more of an in-depth focus, showing some preliminary data for 2014, which has been derived by linking our routine laboratory data with hospital episode statistics. So my case definition is very similar to what's been described in the previous talks. So invasive disease defined according to the isolation of Group B strep from a sterile site or a non-sterile site in combination with meningitis. The data sources I used for this analysis are mainly the laboratory reports that come to Public Health England from laboratories across England and Wales between 1991 and 2014. That data was supplemented, as I mentioned just now, just for 1 year, the 2014 data, with hospital episode statistics. So these are admissions to all NHS hospitals and independent sector NHS treatment facilities in England. And also the data was supplemented through the NHS demographic batch tracing service, which I'll discuss shortly. So I extracted the laboratory data to look at trends over time. The data was sent for tracing to confirm the NHS numbers that were submitted through the laboratory surveillance system. And importantly, the tracing service will also give us the patient outcome. So it will identify patients who died, and it will give us the date of death. And then lastly, using that supplemented data with NHS numbers, we use that to link to the hospital episode statistics for that in-depth review of 2014 data, which is illustrated here. So we started out with 1,670 invasive GBS cases through laboratory reporting in England and Wales, removing the 69 cases who were reported by laboratories in Wales, left just over 1,600 cases in England, of which the majority had NHS number. So we were able to actually make a linkage of a very high proportion of all our cases, around 97% in total. So first looking at the trends over time. So how do these look? So the graph here shows the trends in invasive GBS disease across all age groups. So this is adult and infant disease all combined. And what you'll note is that the incidence has increased quite markedly across the entire population, something that's been reported in many other countries. So it doubled over this time period to reach 2.9 cases per 100,000 population in 2014. But if we break that down a little bit further to look at the age-specific trends over the same time period, then what you can see is that the trends are not parallel in all the age groups. And in fact, although most age groups have shown an increase, in fact all age groups have shown an increase over this time period, not most, all of them have, the magnitude of that change does vary quite a lot. And if you look at the green line, that represents disease in the over 75s. In those individuals, the incidence tripled over that time period. So rather than just a doubling, it actually increased threefold since 1991, so quite a marked change. So because of this differential change in incidence in different age groups, then the proportion of disease which is in infants has dropped quite dramatically over this period of time. So whereas around about half of all invasive GBS cases diagnosed in England and Wales were in infants at the start of this period, by the end where we are now, it's around a quarter. So this graph here gives a focus on infant disease, and it shows the trends in early and late onset infant disease in England and Wales detected through just a laboratory reporting system. And for the early onset disease cases, then in the early 1990s, the pattern was very varied. I can't see any very convincing trend in that first part of the 1990s. Although if you take the period as a whole, and in particular focus on the last few years, it does start to look more concerning, and it starts to look to me much more like a trend. And over that entire period, then we average out a 1% increase per year in the incidence of early onset disease. And clearly, since the publication of the guidelines at the end of 2003, we really don't see the drop in incidence that we might have liked to have seen, which is somewhat disappointing. For the late onset disease, the pattern is a lot more clear. We've had a bit of a drop here, but generally speaking, there's been quite a marked increase in the incidence of late onset disease, which is reflected in Dr. O'Sullivan's talk before mine, where she outlined the increase in late onset disease. One of the other things that concerns us quite a lot, and other countries have seen a similar pattern, is the rise in antibiotic resistance in isolates associated with invasive disease. And this graph shows the rise in erythromycin resistance over time, split by age. And at the beginning of the 1990s, around 2% of isolates were resistant, and this has increased remarkably in all age groups. First, in adults it became higher first, but now it's pretty much the same across all age groups, reaching 22% in 2014. The patterns for clindamycin are very similar, with 18% of isolates now resistant to clindamycin. So if we now look in a little bit more detail at the 2014 data, so these are now the laboratory reports, same data as I've just been showing you, but just for 1 year. And focusing mainly on England for the next few slides. And you can see that the pattern across the country varies quite a lot. So actually, in some parts of the country, the disease rates are less than 1 per 100,000. But here in the West Midlands, the highest disease rate, around 5 per 100,000. So really quite remarkable geographical variation in disease rates. And these are plotted according to the residential postcode of the patient and their family. Now, this may be down to a number of different factors. We don't understand them very well, and we certainly need to explore these very well. One thing that the linkage of our laboratory data to our hospital episode statistics allows us to do is to look at ethnicity, because we don't collect that in our routine laboratory surveillance. And plotting those same rates for that single year according to population rates for different ethnic groups, then we can see there's a huge variation in rates of disease. So the white British are here, just over 2 per 100,000. And in most non-white ethnic groups, the rate of GBS infection appears to be considerably higher. Now, we've seen something like this in Dr. O'Sullivan's talk. She looked at, showed us the age in days of diagnosis of invasive GBS disease in infants. So here, I've just shown this in a slightly different way, but we can see that as per the data that we've already seen, around about 50%, just over 56% of disease in infants is diagnosed in the first 2 days of life. After that, there's a big drop here, and then a continuing spread of diagnoses over the coming 90 days and beyond. So we use a traditional split off at 90 days, but in truth there's nothing magical about that time period, and we do still continue to get disease in infants, of course, of higher ages, but the frequency goes down dramatically. So in 2014, using just the laboratory data, so not supplemented with pediatric data or anything else, then that gives us an overall infant disease rate of 0.7 per 1,000 live births, 0.44 in early onset, and 0.26 late onset. Now, This data here is derived just from laboratory surveillance. We don't need any augmentation with hospital episode statistics for that. But if we do link up HES data, then it helps to tell us, well, what's the value of HES data on its own? And in fact, I was interested to see, of those infant disease cases, how many had a clinical code in the HES data set that indicated they had GBS sepsis. This code here, P360. And the majority of the early onset cases did, 73%, so we would have missed a quarter if we hadn't used an approach to link laboratory data to hospital episode statistics. But of the late onset disease, actually the majority do not have any code in HES indicating that, which just tells us something about using HES in isolation of laboratory confirmation. We have to be a bit cautious about that. Right, so if we look at the age distribution in across all the infant and adult age groups for males and females, so we see here the huge dominance of disease in infants for both males and females. What we also see, though, is here this sticking out lump here for females, so an excess of disease in young adult females. And by linking through to HES, we can examine this in more detail and identify what proportion of these are actually related to pregnancy and childbirth. And what we found is that 12% of all invasive GBS cases, so 185 of those cases, were actually maternal infections. So within that age bracket, so being a woman between 18 to 44 with invasive disease, then nearly all of those are maternal infections. So that translates to a rate of 0.28 per 1,000 maternities in England. So I was interested to look at these cases in more detail, as they're not really very well studied and are something that is of considerable interest. And we can look at the age distribution of those maternal GBS cases, as illustrated here by the red line. And they seem to be broadly similar to the age distribution of all maternities, with a median age of 30 years. They look slightly older to me, but broadly similar to women giving birth in England altogether. Of those 185 cases, 7 were associated with a miscarriage. Of the remaining 178, we could look at the timing of the infection in relation to childbirth, as illustrated here in this figure at the bottom. And the overriding majority here, the diagnosis was made from specimens taken on the same day as the delivery occurred. So we have just around 10% of the infections were diagnosed, what I would call antepartum, may not be the correct term, but just before childbirth, and 17% postpartum, right up to almost 30 days. 26 days post-delivery was the last diagnosis I could identify. And then I thought it would be important to look at the outcome, of course, of those infants in mothers of maternal GBS infection. And using this anti-intrapartum split, so including all of these cases and the ones to the left, in this column, and in the postpartum cases from day 1 onwards, in the right-hand column here, then we could look at a number of different things, and this is very early analysis, and there's a huge amount more we can do with this data to understand the burden of disease. But we can see that roughly half of those women delivered had a normal vaginal delivery or an instrumented vaginal delivery, with 41% and 50% having an emergency cesarean section, so a very high proportion of emergency C-sections in this group. In terms of the birth outcome, this is according to the gestational age given in the hospital episode statistics, then 5% of the anti-intrapartum births were associated with a preterm delivery, as opposed to 18% of the postpartums. And importantly, Alison has mentioned stillbirths, and we did identify stillbirths within this patient group here, with 4% of those maternal infections being associated with stillbirth. And looking more generally at mortality, going back to our bigger data set and looking at all-cause mortality using the tracing service information on death and date of death, then I extracted the deaths that occurred within 30 days of diagnosis. These are all-cause deaths. I haven't tried to disentangle the cause of death. There are lots of problems trying to use death certification data for that, so we tend not to go near it if we can avoid it. But looking at the all-cause mortality, it was 9% altogether across all the different age groups, but with huge variation by age. So, 7% for the infants, which we can break down to a 4% case fatality rate for early onset and 10% for late onset infections, very similar to the data already presented, but with a huge rise as we go up, so rising to 17% in the over 75s. So really quite a substantial burden of disease in the elderly. Okay, so there are lots and lots of limitations to the data, which I've just shown. I mean, laboratory reporting is voluntary, and whilst it's subject to audit, we know that underreporting can and does occur and will therefore underestimate true incidence, which is why we need the enhanced surveillance studies to take place occasionally to supplement the data and make sure that we maximise case sustainment using other sources. And basing the data just on culture-confirmed cases from sterile sites will, of course, mean that cases that have no positive cultures will be excluded from this analysis, and that's particularly a problem for studying infant disease, where it may be a problem to obtain a positive culture from an infant. And of course, the HES data that I've shown is, in particular, the maternal sepsis information is very much reliant on the accuracy of the coding of that information within HES, and it's very important, of course, to go on and evaluate some of this data to make sure that it is valid and can be meaningfully analysed in this way, but it's a good starting point, I think. So just to summarise, invasive GBS disease is increasing in adults and infants, and that could be linked and is likely to be linked to a number of different things, including an increase in the number of adults and infants with underlying diseases which make them vulnerable to invasive disease. The rates of early and late onset disease have not decreased since the introduction of the prevention guidelines, and that's really quite disappointing. We have to be a little bit cautious here, though, of course, because we don't know what those rates of early onset disease would look like if those guidelines hadn't been introduced. It's important that we bear that in mind. The increase in drug resistance is a considerable concern and really does emphasize the importance of antimicrobial susceptibility testing. There's still a lot of clindamycin being used in penicillin-allergic patients. If that's done empirically, without knowing the sensitivity of the isolate, you could be in a heap of trouble here with these patients, as many of them will have resistant isolates. And lastly, that improving our understanding of adult disease will facilitate the identification of target groups for prevention and really help us understand what is the true burden of invasive GBS disease across all the age groups. So just lastly, I'd like to thank all the clinicians and microbiologists around the country for their sterling work in reporting. Without all this incredible activity to report cases to us, I wouldn't be able to stand here. I'd have nothing to say to you today. So I'm very grateful for all of those efforts. And within Public Health England, there are a few people to thank who helped put the presentation together and produce some of those lovely maps and things. Thank you.